Hello, hello everyone. I think we should start for the sake of the time. We have a little delay. Yeah, it's the title. The title of the workshop is Treatment Choices in Type 2 Diabetes, and the workshops. Yeah, if you just could come closer, perhaps. The workshop is basically, you've seen the workshops here before. It's not the first one we are having. It's not really to show any, I don't want to show you any lectures or any, well, I do have some cases just in case, or to illustrate some points. But basically it is designed to facilitate the discussion, answer any of questions you might have regarding the topic. So the topic is pretty broad. It's just treatment choices and how we treat type 2 diabetes. So well, let's start with you. Do you have any burning questions, dilemmas, issues, problems with your patients? Maybe some particular patients you think you don't know, or you're not sure the decision was correct? Are there any questions on your side? You look as if you could ask a question. No? No? Not more questions at all. Okay, majority of you are from Egypt. What is the treatment choices you have in Egypt? You have metformin, of course, yes? You have sulfonylurea. Do you have any newer agents? So you have pioglitazone, yeah? DPP-4. And SGLT2 inhibitors you also have. And CETP. So you have all oral agents, basically. Yeah, patients have to pay for that. Yeah, is it expensive like GLP-1? Yes. So how many of you have at least 10 patients on GLP-1? How many of you? 1, 2, 3. Okay. So people are, well, if they can pay, they will pay for GLP-1. And of course with insulin, you have all the insulins, yeah, human and analogs, long-acting and short-acting, yeah? And premixed, every insulin. Is insulin reimbursed? All of insulins are reimbursed? Only premixed insulins are reimbursed. And analogs, short-acting, long-acting, the patients have to pay. It's covered by insurance as well. Yeah, the reason I'm asking is because in many countries the money is the barrier. Yes, we would like to treat patients how we would like to, but the patients simply cannot afford it. Okay, so we can discuss all the options, because sometimes in the countries where we go, where we were in Mongolia, for example, 2 months ago, and they had no SGLT2 inhibitors yet on the market, so there's no point in discussing it. Okay, any questions? Yeah, okay. If you could have a microphone, because you have to speak to microphone. The room is big and the others will not hear the...
We are facing adherence of patient for treatment.
Adherence?
Yeah, and how we can improve it?
Well, it's a great challenge. How do you help your patients follow your guidelines, your recommendations? What do you tell them? Do the patients stop anti-diabetic medication? That's the one thing. Do you see it? Sometimes they stop. So what do you tell them to continue? Is there any trick you're using? Yeah, about the complications. We talk about the complications. One thing I do is that I do relatively frequent HbA1c measurement, at least every 3 months. Well, not at least, 3 months makes sense. Shorter time doesn't make much sense. But I also try to explain the patient what HbA1c is. And you might find it a challenge, but when I tell the patient, look, there is a protein in your blood which carries the oxygen and it makes the blood red, and it's called hemoglobin, and when glucose hits it, it binds to it, and hemoglobin lives. Do you remember how long hemoglobin lives? 120 days, 4 months. So I say, so you have the mixture of your, at various age of your cells with hemoglobin, And I usually tell them, imagine that some cells leave your bone marrow today and will die in your spleen after 4 months, and some of your cells are dying in your spleen. They can somehow surprised, they say, oh, this is really happening. But then it helps them understand what we measure, really. And I must say, I feel greater problem with adherence with statins, for example, because that is just measuring, we don't know, it has no influence on their well-being, it's no complaint, and the effect of taking statins is years ahead. But if they stop taking anti-diabetic drugs, in a few days they might have high blood glucose and they might feel unwell. So I don't think adherence is not as great as in statins or aspirin, for example, when you take. Also, blood pressure pills are usually well taken, because if you don't take it, then you do feel unwell pretty quickly. One thing which we try to use, and we follow hypertensiologists, is we use fixed dose combinations. Do you have these drugs? Like sitagliptin with metformin? So this is one option, and they are as expensive as without metformin in my country. So it doesn't increase more, it doesn't cost more, okay?
We receive many cases, diabetic type 2 with ultrasound abdomen, bright liver, and elevated liver enzymes. When we consider NASH, I know the golden standard is to do liver biopsy, but this is practically, this is so difficult and expensive. Can we depend on non-invasive measures that, like, as you know, when to consider NASH, when to consider only NAFLD, and the treatment?
So this is a question about fatty liver disease, about NASH, which is non-alcoholic steatohepatitis, which is hepatitis, so it's an inflammation, it's a more advanced stage, or NAFLD, which is non-alcoholic fatty liver disease, which is a very broad and general term. Do you often see bright liver in the ultrasound of your patients? Yeah, I think all of us. If you see it, you probably check alanine aminotransferases, liver function enzymes, yes? If they are elevated, do you prescribe metformin? Who doesn't prescribe metformin when, well, let's say ALT is above 100. How many of you would prescribe metformin? Okay, you would prescribe. You wouldn't. You would prescribe. Who else would prescribe? Most of you does this. Okay? But it's better to show hands, I must say. When I was if you ever travel to Bulgaria, by the way, you don't have to because you have a nice weather here, but I'm in Northern Europe, so we travel to Bulgaria to the seaside. This is opposite there. They do this for yes and that for no. So whenever I see, I was just there recently, and no, the problem was in a restaurant. I went to a restaurant and I asked a waiter, could you bring me some water? No. Could I have this? Could I have that? And I said, oh, what a rude people here. They say no to everything. And it took me a day to remember that it's the other way around. Okay, so above 100, most of you wouldn't prescribe metformin. Above 80, who would prescribe? If it's 81, who would prescribe? You would prescribe, increasing number. So if we go lower, the more of you would prescribe. That is an interesting thing, because it shows that it depends on which doctor you go to, how many pills you're getting. Yes? Because if someone with ALT 120 would go to you, he would get metformin, or to you, or if they go to the back rows, he wouldn't get a metformin. So that's interesting. It is relatively simple nowadays, because NAFLD is the feature of obesity. If you're overweight, the liver will accumulate in the liver. Ultrasound scanning is so perfect now that they can detect any amount of liver, of fat, or this bright liver picture. And you are right that the gold standard is liver biopsy, but we never do it. Basically, we don't recommend it. What you can try to do, because the key issue here is whether it's just fatty liver, so NAFLD, what you mean, or whether already the process turned into inflammation, which is a direct way to fibrosis. And now, I'm not sure if you, the technology must be in Cairo and in Egypt, but I'm not sure you can access to it. But there are newer types of ultrasound machine, which is called FibroScan, and you can do fibroscanning, which is almost as good as liver biopsy. But still we don't do it, basically, because it's not really, you ask about the treatment. There is very little treatment for moderately advanced fatty liver disease. And you can consider two agents which you can find in the recommendation. Last year, in 2016, there has been a pretty big paper, large paper, published by EASD, European Association for the Study of Obesity, and European Association for the Study of the Liver. And they presented the algorithm for the treatment. And you can really consider two drugs only, apart from metformin, which is pioglitazone and vitamin E. That's it. So the clinical practice is, I think, and it's quite widespread in Europe, that we see high liver enzymes in patients with fatty liver disease, and you can safely use metformin or any other drug if it's no higher than 3 times upper higher limit. So that if higher limit is 40, 45, so you can use it to 120, 130. I use it up to 150, I must say, and I do it with ALT, and I do it because I've seen many patients in whom I start metformin with ALT up to 150, and it goes down very nicely. The same thing is with the statins. Statins also helps to fatalize liver, to decrease the fat in the liver. If it's over 150, then I think, okay, maybe it needs additional checking. So we check for hepatitis C, but we quite do it routinely nowadays. We have increasing cases of hepatitis A. I guess it might also be present here, because the more south you go, it's more frequent here. And we only refer to, we don't refer patients to hepatologists. We only refer them when we think liver biopsy is necessary. But then they do it when there are first sign of cirrhosis in ultrasound. When the ultrasound, you say, oh, this is a very grainy liver, not just bright, but with a grainy picture, the descriptions we are getting. And then it may be indicated to go to hepatologist, do the biopsy, and see if the patient developed cirrhosis. And we prescribe pioglitazone at the later stages, quite frequently. Fibrobiochemical tests, they are not very sensitive. They are not very sensitive. I'm currently collaborating with our hepatitis and infectious diseases department. One of the colleagues is doing project in assessing it. It's rather fibroscanning, which works very nicely than doing these biochemical tests. And what you can do, I would really encourage you to use metformin at higher levels, as long as ALT is higher than AST. Yes, because if AST is higher, but I don't think it is so frequent in your population, because you definitely drink less alcohol than in Europe. I'm not saying you don't drink. We were in Iran a few months ago when I said, and there were doctors sitting here saying, oh, you're lucky you have no alcoholic cirrhosis because you can't get alcohol anywhere and you don't drink it. And they are laughing. They say, no, we all drink alcohol. You can't buy it, but we know how to get it. But you definitely drink it less than in Europe. So we often see AST much higher than ALT. And it's a very clear sign that the problem is in alcohol. And that is a slightly different treatment. First of all, they must cut down on alcohol. And they go very quickly into stages. Yeah.
Which is most specific for NASH? ALT, AST, GGT?
ALT, absolutely. Well, it's the relationship between them. ALT should be higher, and it's often 2 or 3 times higher than AST. And GGT TP or GGT, what they say, is gamma glutamyl transfer peptidase. This is a marker of alcohol intake. We use it it's a very sensitive in people. If we have a patient, GGT, we have a patient who says, I don't drink, and his GGT is just sky high, we know he lies. And also for cholestasis, it's also sensitive for cholestasis. So we know that there might be a problem in the hepatocytes as well.
Because I received many cases, many diabetic cases with fatty liver in sonar.
Yeah.
ALT is normal, AST is normal, GGT is high.
That's interesting.
Well, we haven't, the drinking alcohol here is...
Yeah, I know. I would, if this is the case,
Yes.
there might be something going in the bile ducts with some, it could be even a minimal obstruction in the bile ducts. So I would even consider, if it is persistent, to do endoscopic, cholecystopancreatography to see if there are any bile stones there, or even biopsy. It's quite unusual in general to find fatty liver with normal ALT. But the one message is it shouldn't stop you from using metformin, it shouldn't stop you from using statins, and pioglitazone is directly indicated. And pioglitazone works very well. Then it improves liver function immensely. So as much as it may cause edema, or we kind of like it in fatty liver patients.
If GGT high, to stop metformin?
Oh, that's a difficult question because there are no indications here. At what level you would stop metformin? The normal is
Depending
about...
on serum creatinine or glomerular filtration rate.
Yeah, then you would stop. But at GGT,
If it is less than 30.
yeah, but you say GFR. You
Yeah.
say, the glomerular filtration.
Yeah.
Oh, yes, of course. You should, if it comes to kidneys, you stop metformin at 30, and you should stop it because it might be dangerous. But and this is Professor Bolton said it yesterday, we continue in prescribing metformin well below 60, between 30 and 60
Half
patients
dose.
in their 45, 42, we still prescribe it. We
Half
slightly
dose.
decrease the dose. We slightly, we up to half, but we continue. The problem, again, if we talk about metformin and decisions here, if you stop metformin in patients with kidney failure, there is very little option to use as the treatment. Yes, it's mostly insulin. So you stop metformin, glucose goes high, you have to increase insulin, and people put on weight, and then the glucose goes even higher because they're more obese. So it's a kind of a vicious circle. And for kidneys, glucose is absolutely crucial to stop the deterioration of kidneys. Not as much as for the heart, as we know, but for the kidneys. So we'd rather keep metformin as long as it is only possible. And in many cases, you can elevate GFR because many patients are dehydrated if they come to hospital.
Infection?
Yeah, infections. You have to be, okay, we stop metformin, we try to work on the patient to improve kidney function, and we can go back to it. Because, again, I've seen many patients in metformin was stopped. The only solution was increasing insulin, and they were never as well controlled as they were taking metformin. So we're very fond of the drug, and we continue as much as possible. Okay. Well, I wouldn't say it's nephroprotective, but it simply helps to control blood glucose in obese people. If you have an obese patient and you treat him only with insulin, it's much more difficult than you use insulin and metformin somehow. Yes, so we see a big difference when we stop metformin, glucose goes high, and it's difficult to control with just insulin. And especially that people with kidney failure are usually older. They don't walk a lot. You cannot tell them you spend more energy. So they sit more, they take more insulin, they eat what they have eaten already. I mean, the regular food habits do not change, and then they put on weight. It's very similar to heart failure. one of the signs of heart failure is weight gain, because people eat as they used to eat for years, but they stop spending energy, and then they put on weight, and they're very difficult to treat. Yep.
I have two cases in my clinic. One of them is 35 years old, female, on insulin. She was in analog insulin, now in Mixtard. She take about 1.5 unit per kg. Her weight not increased, but her blood
1.5 insulin unit per
insulin
kilogram.
unit per kg. Her weight not increased, but her blood sugar increased. Her blood sugar profile appeared to be increased, and we increased the dose. Our iron weight not increased, but her blood sugar increased irrespective of increasing of insulin unit.
So you increased insulin, and the blood glucose also increased.
It still increased, without increasing in body weight.
Okay.
I don't found any correlation to
Is
that.
she obese?
No, she
She's
is overweight.
She's overweight.
Yeah.
So you increased the doses. Glucose
Increases
was
from-
going up as well.
Yeah, from 1 unit.
Okay.
to now we reach 1.5 unit per kg, and still her blood sugar increased. We don't found any data.
Well, there could be several answers for that. One is she long-standing diabetic for years?
Maybe 5 years.
5 years,
5
not
to 6
long,
years.
not a long time.
Yeah.
Any ideas what might have happened? Yeah. Hmm? Eating habits.
Yeah, we make a stress regarding the lifestyle and
Yeah.
eating a habit, also exercise. We try to do whatever the changes in lifestyle that help us to control. But the main noticing in her profile, day by day, maybe twice weekly she'd come.
Yeah.
But her blood sugar, once we increase the dose, her blood sugar increased. So we try to reduce the dose, well, again her blood sugar is still higher.
So you decreased the dose,
Yeah.
and what happened to blood glucose?
Still higher.
Nothing.
Nothing happened.
Nothing happened.
Nothing happened.
Are you sure? Are you sure she needs insulin?
Yeah.
Are you sure she needs
She is
insulin?
an insulin, yeah.
Was she treated with oral agents before, or did she start insulin from the beginning?
She was an oral,
Yeah.
maximum oral, then there is oral failure, not responding, so shifted to
Yeah, so maybe she's LADA or type 1 diabetes patient with overweight, and then it's difficult to treat. Well, there could be several reasons. One of them I would think immediately what you said, that the more patients, this is the trap young doctors often feel into, because, oh, you have high blood glucose, so I will increase your insulin. So, and the patient comes after a month, and it's even worse, so I will increase insulin more. But they put on weight. So if she didn't put on weight, there might be something different, not just eating problems. Yeah, that's the second thing is insulin injection sites. But she's only 5 years. If she was like 20 years with diabetes and 20 years on insulin, we always check injection sites. And you'll be amazed how changing the site of injection may improve glucose control. We have patients admitted to my department just because of the poor control of diabetes. We see the patients, we check the sites, say, okay, let's change the sites to the arm or sometimes to the back. You can make an injection, someone can make, into subscapular area. Suddenly the patient is cured, or well treated, well controlled. No, the problem disappears. The other things I would check autoantibodies, because she might be, if she's young, 35. Did you check GADA antibodies?
No, check.
I would check it. It's not very expensive and it's surely available here. So if she's type 1, then maybe Mixtard is not the good idea, because Mixtard insulin is a case. The premixed insulins are difficult to titrate the doses. And in young people, I must say, we don't use it. We only use premixed insulins in the elderly who have very stable day after day. If you have a 35-year-old, she will eat later or earlier breakfast meals, skip the breakfast. There is a lot of stress in the life when you work, have a family and so on.
Yeah.
So it's a challenge.
Yeah, she was an MDI.
Yeah?
She was in a multiple daily injection of insulin.
Okay.
and also it is not she not respond to this.
Okay, so I can, so if you refer the case like to me, to my outpatient or to my colleagues' outpatient clinic, eventually what we will do, we will put her to hospital for 2-3 days, and we would give her insulin IV, intravenous infusion. We use a special protocol. I've been working with that for over 20 years. When we give insulin infusion between the meals, it is just the rate like 1 to 3 units per day, per hour. And then we use the bolus protocol. I can actually show it to you because that's, you might find it useful. And we do it, that's a case I prepared just in case you, can I have my, and then we do the boluses for 90 minutes. And we do it in hospital. Well, you can only do IV insulin in hospital, but we do it to assess insulin requirement. So we see whether the patient actually needs insulin, because if you give insulin IV, you eliminate subcutaneous route of absorption. And insulin given intravenously always works, always. There are no cases it doesn't work. And so we can calculate the requirement, and we also bring the glucose to the proper levels, good levels. So we kind of reset the organism, and that's what we would do. Or the other thing, we would look for other causes for, poor metabolic control. It could be liver, could be some infections, could be some endocrinology things, maybe thyroid. There must be something. It's not, it's not a, it's biology. But I just want to quickly show you one case it's not about insulin infusion, it's about extreme insulin resistance. We had a 72-year-old man who, actually I could do it from here. Yeah. We had a 72-year-old man who was referred to us from endocrinology department, very high blood glucose, and he felt, and basically it was a new case of diabetes. He started to have diabetes. He was admitted to other endocrinological department. He was there for 3 weeks. They said, we can't help his blood glucose, and they referred him to us. At the moment of diagnosis, he was dehydrated, he felt unwell, but no infection, no ketoacidosis. His medical history was that he was after a myocardial infarction. He had implanted ICD device, he had neck spine surgery, and in 1940s he had tuberculosis. Basically nothing great. And this is what he looked like. Yes, a very slim person. I mean slim man, yes, 72-year-old, non-obese. We looked for signs of acanthosis nigricans in him, so maybe this, but we were not really sure. Also, there are his armpits. Well, you can't see it here, but there was a little darker patch here. I guess you're all a little bit more dark-skinned, so it's more difficult in your patients. But this is the protocol we use, and that's why I'm showing you this. So this is the insulin he started with. This was last year in May. This is his blood glucose. If you use millimoles per liter, use millimoles, yeah? Milligrams, great, because it's the same we do in Poland. So he started high, and we started to giving 4 units of insulin per hour. It's quite a lot, intravenously. 4 units per hour means 100 units per day. Yes, but IV. And look what happened, 4, 6, 7, he's still well over 200. And this is the meal boluses. And the meal boluses consists of 90 minutes insulin infusion, but with 3 rates, 3 speeds. This first rate goes for 20 minutes, this goes for 20 minutes, and this goes for 50 minutes. So we try to restore this early peak of insulin. Yes, so that's we can manipulate those rates of insulin infusion to give more at the beginning of the boluses, and the smaller amount at the this latter part of the meal boluses. This protocol was brought to our department years and years ago from, I think, the colleague, one of my older colleagues went to Strasbourg in France, and they used this protocol, and we use it with quite a success. And we check, so here he got 10 units for 20 minutes. So how much insulin he got through this period? 3, yes, 20 minutes, 10 units per hour. For 20 minutes, it's about 3 units. Then this for 20 minutes. So again, it was 4 units. Yes, a third of, because it's 20 units per 60 minutes, but only for 20 minutes. So 3 for 7, and this went for almost an hour, 50 minutes. So altogether, he got like 15 units per meal, per this meal, but intravenously. And it didn't work, yes, after he had over 300. So look what happened. We increased the doses. We went to 14 units per hour intravenously. 14 units per hour. And the meal boluses, I've never seen a patient like that, I must say. That's why I'm showing you this. The meal bolus was a third of this would be like 8 units. A third of this would be 10, so it's 18. And about 20, close to 40 units per meal intravenously. This is the amount of insulin which would kill a horse. Yeah? And he was like 300. So this is how it went. Yeah? This is about 30 units per meal, 8 units. And it started to change. During the second day, the blood glucose started to come down. And we discharged him, when he was admitted, his HbA1c was 10.6. This is in Polish, but we discharged him on insulin, on metformin and pioglitazone, because we added pioglitazone during this insulin pump, IV pump, it helped. And we really wondered what happened. Do you have any ideas what could be the cause of such an extreme insulin resistance? What could it be? Absolutely, yeah. All we came to is perhaps he's got some autoantibodies. And we measured we took his blood and we measured, this is what he was discharged with. It was insulin, like human insulin, yes, regular and isophane, NPH, about 30 units per every meal and 30 units at night. Pioglitazone, glucophage, some other drugs. And we checked, I'm not sure if you can see it, we checked his insulin autoantibodies, and this is the result which arrived later. It's 3, almost 3, and the upper normal limit was 2.4. So this was what we decided the reason. This was the reason, oh, this is something. So he developed insulin autoantibodies, and perhaps if we treated him with animal insulin, it might be better, we don't know, but with human insulin. So he developed autoantibodies, and then look what happened later. This is July, and his blood glucose is very well now, 70 to 120, and he's only on oral agents, glucophage and pioglitazone. The doctor who was overseeing him decided to stop insulin, and eventually in August, they stopped all the drugs. So probably it wasn't diabetes even. Yes, it was somehow the bout of insulin autoantibodies production. But then we found out what was the eventual reason. Because when we looked at his charts, and you can see it here again, it's like, this is his May stay in a hospital. This is, we admitted him again in September to do the tests. And if you look here, his platelets are low, yes, 96. His, what is it? His red cells are 4,035,000. And if you look 4 months later, his platelet came to 70, and red blood cells 3,300,000. Yes? So he started to be anemic, and we thought, okay, there might be something here. And if you look at white blood cells, it's 4,000. Yes, close to 5,000, and if you look at white blood cells here, it's 3.4. So all his blood cells decreased. So he was going into pancytopenia, and eventually we did bone marrow biopsy, and he was diagnosed with myelodysplastic syndrome, MDS. So this was the ultimate cause, as we decided, for his extreme insulin resistance. But this is just an interesting case. I simply wanted to show you this pump. So this is what I would do. I would put her to a hospital, treat her with insulin IV, and see if she really needs it, and how much she needs it. Yeah, and in a hospital, she's got a controlled food intake, usually. We can assess how many calories she's taken. And I would do, yeah, she's only 35. I would do something with it. Yeah.
Yes, it is a great courage of you to use bioglitazone with an age like that, 75.
After myocardial infarction. Yeah. But he was
age, and using, there's also objection about the age 75. Also, many controversy about using insulin with bioglitazone. Many of Egyptian refuse this. But in practice, it gives good results.
We give it.
But with an age less than that.
Yeah, but we were desperate here. That's not an usual case. Well, actually, it's not diabetes. I'm just showing you that you may need up to 300 units of insulin per day and still not having diabetes. Is a chronic hyperglycemia. This was the complication of some autoimmune or immune process which led to extreme insulin resistance. And we used pioglitazone simply to improve insulin action. We didn't know what was the real cause. The indication in him was myocardial infarction, but he had no signs of heart failure. So, and it was in hospital, so I thought it was safe. The problem with pioglitazone is that it starts its action very slowly. You start it and you see the results after a month or 3 weeks. You can combine pioglitazone with insulin easily. Again, if I show you some algorithms, the usual ones, what we always look at, it's this one. It's absolutely, can I have this slide, please? That slide you know very well. Yeah? You can hardly see it. But if it's a lot of running here, which is good. The TZDs are here, and you can combine them with insulin officially. And the reason why we do it is that if we have patients on high doses of insulin, taking 150, 200 units of insulin per day, they are obese, the pioglitazone works nicely. The only problem is they might gain a little bit more weight. So we simply control them more often. But there should be no objections to combine these drugs.
Can I ask a question about insulin usage? I heard yesterday about insulin analogs.
Yeah.
Rapid-acting insulin. To use, as we prescribe for our patients, to use it just before meal or during meal or one quarter after meal. But I heard yesterday or the day before that I must use it a quarter of an hour before meal. What is your opinion?
That's what
is the right?
Yeah, we see it in patients. When insulin analogs, short-acting analogs, or rapid-acting analogs, we call them, arrived, the idea was you can use it closer to the meal, so it will be more comfortable for the patient. With human insulin, we tell the patient, okay, take your insulin, what we do in clinical practice, take your insulin and start preparing your meal. Yes, if it takes you 15 minutes, fine. If it takes you 40 minutes, fine. You cannot expect people living everyday life to take insulin always 20 or 30 minutes before a meal. So analogs was supposed to be able to be taken just immediately before the meal. But what we learned over these years, especially in type 1 diabetes patients, that they also need time to get absorbed to blood, because this is only when insulin works, and to work. So although companies say you can take our rapid-acting analog during the meal or even after the meal, of course it's better to take after the meal than don't take it at all.
Young children.
But basically it should be taken before, and it's not just 5 minutes, 10 to 15 minutes before the meal, they should be taken. Because still, even if the hexamers of insulin, they degrade rapidly into monomers, it's still, it takes some time. So you have, we don't tell the patients, take it if you like after a meal. There is the brand new, the shortest acting insulin from Novo Nordisk, you might have heard, FIASP it's called. It's aspart insulin which is supposed to act 9 minutes sooner. But it will be very good for the pumps, insulin pumps. But I still don't think we will be able to give it after the meal. There are unusual, well, not very typical situations where you have to take insulin after a meal, and that's the pregnant women who, at the early pregnancy, who vomit very often. So we tell them, okay, have your meal, see what remains, if you can keep it, and then take your insulin. Otherwise, they have hypoglycemia. And also, these rapid-acting analogs were actually invented not for all people, they were invented for children, because you never know with a child how much he or she is going to eat. So this was the idea, we will have a very fast-acting insulin that the mother can decide when he sees, you know, what the child has eaten, and then he will adjust the insulin dose. But it's not really, it doesn't really work. Yeah. You have a question again? Yeah.
I have one question. Sometimes our patient become controlled, and we can see the aggressive course of complication, even in young age, about 30 to 40 years. So blood sugar controlled, blood pressure controlled, dyslipidemia on anti-dyslipidemic measure, but there is a complication like nephropathy and retinopathy, progressive course. This is related to genetic or
There might be some genetic things, especially in nephropathy and retinopathy, in microvascular complications. There is a strong genetic determination. But there must have been some period of poor control. Again, it's not magic. When we see patients, again, very recently, I had a policeman, a 32-year-old policeman with type 1 diabetes, which he was hiding. You know, he wasn't telling to his superiors because he was a policeman. And he only had it for 6 years. And when he came to me, I controlled it very well, I controlled it very well. But when we really went into his history, his papers, his lab results 3-4 years ago, his HbA1c was like 11, but he didn't do anything about it. And he's already on dialysis, and he is half blind. So it's a very sad story. And I think when you really, on the other hand, we see patients, again with type 1 diabetes, who are relatively well controlled since the beginning of the disease. I've been working as a doctor like almost 25 years now. So and I started my work at the diabetes department. So I have in my outpatient clinic, I see patients whom I started to see as a very young doctor. They have type 1 diabetes for 22 years, not much complications. It's not that I'm a great doctor, they simply follow basic rules. They're not perfectly well controlled, but they're more or less okay. So if you have these complications, it could be genes, but I think there must have been period, it could be years ago, at the very beginning, especially if it's type 2. If you have a young 40-year-old, usually overweight or obese type 2 patients, they might have been long time in hyperglycemia and not diagnosed. Yeah.
The other thing is like a true case came to our clinic with random blood sugar 27 millimole, around 500 milligrams.
Yeah, 27 millimole, very high.
Started on insulin, C-peptide was low normal, antibody negative, thyroid function test normal, and patient started on insulin, upgraded dose, become normalization blood sugar profile at least. After that, patient about 16, 17 years, and BMI around 18, 19. Slim. With time, he started to drop insulin, and his blood sugar become normal. Now on lifestyle, beta cells and C-peptide become 500 middle
Yeah.
normal, and about 9 months he is in on lifestyle only. So this patient, we
Is it type 1
consider-
or type 2?
or it is a honeymoon stage of type 1?
Well, we see patients like that who come to a hospital, very high blood glucose, 300, 400. They get insulin for sure because at that level only insulin works. And after a few months, they don't require anything. If they lost a lot of weight, that we say, okay, this is type 2, which, someone restored normal insulin sensitivity by losing weight loss. But there might be type 1, which is called type 1b, when you cannot detect regular autoantibodies, but there might be other autoantibodies we don't measure regularly. So it might be type 1. This person definitely needs monitoring, and it could be a long honeymoon period, yes? So it might be kind of a LADA case, but very slowly developing. But this is basically easy. You just check the glucose, and if the glucose is going up, you may think, okay, is it pills or insulin? If she's slim, I would rather think about insulin, yeah? So that's perfectly. Let give him a chance. Yeah, okay, and you have a chance too, okay?
Is there any maximum dose of insulin?
Sorry?
Is there any maximum dose of insulin?
No, there is no maximum dose of insulin. Never, ever. You will not find it in any books. My experience is I have patients who take 450 units of insulin per day, and they are not extremely obese. They just they are overweight. They just have high insulin resistance. But of course, doctors who do not treat regularly people with diabetes or with insulin, when they see someone taking 150 insulin units, they say, oh, that's very high, you mustn't take more because what? No, there is no, you can use any insulin you like, okay?
As a new doctor or a new physician, how much time I would the art between a combination of oral hypoglycemic or insulin, early insulinization or not?
You mean when you start
يعني, young
continue insulin and oral agents?
no. I would you to describe the art of combination of these a lot of choices of oral antihypoglycemic, like many case scenarios, and it is the best here, it is the best here.
That's the beauty of diabetes care. That's the beauty of diabetes care. I'll show you some other answer for this question. I'll show you what they do in Switzerland. This is the latest Swiss guidelines from last year, because I guess they had the same problems. There are so many drugs which one to choose. So what they say, I'm not saying you have to do it, but I think it's a useful approach. You can think about it. When they have a type 2 diabetes patient, they ask 4 questions. One is the patient insulin deficient? And if it is, and they say, oh yes, he needs insulin because he's rather slim, or they start with basal insulin, then they quite quickly combine with GLP-1 receptor analogs. As I told you already, it's easy there because everything is reimbursed. Then they ask the question about kidneys, and if its GFR is below 30, and it's 2.4 of all type 2 diabetes patients in Switzerland, it's only DPP-4. You can use some DPP-4 inhibitors at lower doses, or like linagliptin, or GLP-1 receptor agonists, and then basal insulin. The third question is, do the patient have cardiovascular disease? And if yes, and that would be a quarter of patients, which half of them will be asymptomatic, you can use metformin, either empagliflozin or liraglutide, as we know from the recent studies. If no, still you can use metformin with SGLT2 if someone is more obese, or GLP-1 receptor agonists if they can afford. We love GLP-1 receptor agonists, I must say. We would, if we could use it much more often, or DPP-4 inhibitor, especially in the earlier stages of the disease, because the difference between SGLT2 and DPP-4 inhibitor is that DPP-4 inhibitor will not work after quite some time of diabetes, or you can use basal insulin. And the fourth question is there any sign of heart failure? And then the drug of choice is really SGLT2 inhibitor. So this is how they do it. They don't look at AASD algorithm, they use this protocol. And it might be, I think it's quite useful if you have all sorts of patients. What is happening now, I can also show you what is happening in the West is, yeah? It is, yeah, it's, yeah, I'll try to show you this. This is the secret slides. I wasn't allowed to take these pictures. They almost throw me away from the lecture hall, I must say, because these are the data from, I know it's, oh, I can use the mouse here. It's not very well, it's not very clear, but as I said, they're secret pictures. This is the sales of the drugs in Europe, oral agents for diabetes. This upper curve here is metformin. So the metformin is on the rise. What do you think is this green one? What do you think is it? DPP-4 inhibitors. No, sorry, no. That's sulfonylureas. DPP-4 inhibitors are here. So this is what is happening. I might have a, let me show you. I might have a better resolution. Oh, this is slightly better. So this is what we use in Europe. Yeah, we talk about all new agents, but this is what happens in Europe. Metformin is on the rise. The green one are sulfonylureas going down, and DPP-4 inhibitors are going up. So the most preferred choice now is start with metformin, add DPP-4 inhibitor, or SGLT2 inhibitor. I will be telling in my lecture today about it. If you have someone with cardiovascular disease, you should start empagliflozin as early as it is possible. Let's see if I have something from Germany. And that's the DPP-4 inhibitors family. This green one going up is sitagliptin, and the orange one is linagliptin, but basically all of them are going up in Europe. Yes, these are the sales. That's SGLT2 inhibitors. Dapagliflozin is the highest one, but empagliflozin, the green one, is catching up because of the EMPA-REC results. Just to show you what is the market for SGLT2 inhibitors, 10% of patients with diabetes in Switzerland and in Austria are using SGLT2 inhibitors. But if you look on the left, France, Italy, it's about 2 to 3%. So still few patients. Yeah, pioglitazone is used less and less often. Mostly because we have DPP-4 inhibitors and SGLT2. That's the Germany. Metformin is on top, and DPP-4 inhibitors are much higher than sulfonylureas here. Yes, that's this red one. This is DPP-4 inhibitors, and this is sulfonylurea. In some countries like Finland, Switzerland, sulfonylureas are not used at all, really. So this is the market, how it changes. Yeah, that's what doctors, primary care physicians choose in Germany as a second drug to metformin. These are DPP-4 inhibitors as the leading ones. And then it's sulfonylureas falling down, and this yellow one is SGLT2 inhibitors. So that's the trend in Europe now. So I think most of the doctors are right. This is what they do. Trying to answer your question, okay?
Do you prefer a combination between metformin and pioglitazones, or metformin and DPP-4 for insulin resistance?
Yeah, we try to not avoid pioglitazone, but we really have to have a good reason to prescribe pioglitazone. And the good reason is apparent insulin resistance, NASH number one, I would say NASH number one, and then patients with real insulin resistance. But the best treatment for obese patients with insulin resistance is, again, we sometimes put them to hospital if they're on high doses of insulin, give them insulin IV, and I could show you loads of patients who come to us on 150, 180 units of insulin where their doctor was helpless. They said, okay, I increase the dose, glucose only gets worse, do something. And he comes to us. We put them on insulin IV, we level the glucose, and the patient is discharged on 50 units of insulin, just a regular typical dose. Because the healthy person, as you know, produces usually 0.4, 0.5 insulin per kilogram. Anything over 1 unit per kilogram is way too much. What is... No, nothing goes wrong. If you take insulin, if you take a little too much insulin, you start putting on weight. Insulin is an extremely powerful anabolic hormone. We have, if you ever treated or have a contact with bodybuilders, you know, people who do the gym and build their muscles, they use insulin as a bodybuilding thing because they cause hypoglycemia. They eat a lot, mostly proteins, and this is immediately used by the body to build muscle mass. So this is a powerful anabolic. We know, for example, when a patient has hypoglycemia, which he or she does not detect, when they start putting on weight, that means they get too much insulin. And even little too much already will make them put on weight. But the regular reaction of doctors is, okay, your glucose is higher, you put on weight, your insulin is working worse, you need more insulin, so we give you more insulin. And insulin also acts on the brain, it stimulates appetite. So people simply eat more, especially in high doses. And you have to break this vicious circle. That's why giving insulin IV helps in such cases. So there's nothing wrong with the doctors, it's just very powerful drug, which is difficult to use in everyday practice, yes, to adjust the dose to the meal. And the body, we all, including me, we don't realize how excellent energy-saving machines we are, our cells. And the best way to combat insulin resistance is just to put in a hospital, cut down the diet, really, and cut down insulin dose through this IV infusion. You could do it outpatient as well, but you would have to have a good educational team, and the patient would have to come every day for a week. Yeah, yeah. And in the hospital, and also if you put them to hospital, they are miles away from the refrigerator, yes, so it's difficult to get more food, and as long as the family doesn't bring them anything, yes, that's again difficult. So there is nothing wrong, but it's just we play hide and seek with metabolism, which is, it's always a challenge. Or insulin. I prefer what patients prefer. I always prefer what my patients prefer, because if I don't follow patient preference, I will have problems with adherence. Yes. So with current number of drugs and insulin, we can tailor the therapy to the patient needs. And whenever I don't know what to do, I always think, okay, if it was me, if I was this patient, how I would like to be treated. Or I think, if it was my mother, I had good mother, so if it was my mother, how would I like to treat her? And then I know the answer. So almost always I'd rather use 4 oral agents rather than insulin. Especially that in type 2 diabetes, insulin is a kind of a rescue treatment. If you look what is happening now, we are delaying insulin therapy now with all the new agents. Sitagliptin could delay insulin therapy by 30% need for 4 years in patients still on oral agents. We know it from TICOS study. And if you think it this way, imagine someone would like to register insulin for type 2 diabetes today, when we have metformin, pioglitazone, acarbose, sulfonylureas, DPP-4 inhibitors, GLP-1 receptor agonists, SGLT2, 7 groups of drugs. And someone comes, oh, there is insulin. We can also use insulin for type 2. But then people would say, well, people are obese with type 2 and we are giving insulin, which makes them only more obese. It causes hypos. No. I think registering insulin today for type 2 diabetes would be extremely difficult. So it's not and basically these patients produce insulin. In type 2 diabetes, you produce insulin for a very, very long time. Probably always, even if you have type 2 diabetes for 30, 40 years. It's the question of calorie intake, it's the question of stimulating its action, its secretion, and you can do it with the drugs, but the problem is the cost. Okay, I'm afraid we have to finish. Sorry, but unless there is a second round of workshops, unless you want to stay and you don't want to go any other workshop. You're staying or you're going to the other workshop? You're staying. Okay, we can continue. One more. Okay, go ahead. We have a microphone here.
During using basal bolus regimen, the policy of fixed fasting first.
Yeah.
Can I fix? Can I adjust optimizing fasting, and during the same time I optimize the big
Postprandial,
meal, the
yeah.
big
Absolutely.
the big meal?
Yeah,
Can
absolutely.
the same time?
Yes, same time, absolutely.
Maybe.
This policy of, if you introduce basal bolus therapy, the policy of first we check the fasting and then we do the postprandial is just to make it easy for the patient. That's the only rationale. That okay, measure, we will look after post-meal glucose later, dear patient, check the fasting first. But you can do it at the same time.
We do optimization every 3 days. Every 3 days I can adjust the basal with the same time to adjust.
Yeah, yes, we adjust
one of the-
prandial. That's what we do in hospital.
No problem.
No problem, because in hospital patients stay with this protocol. We keep them, we give this insulin pump, IV pump for 2-3 days, no longer, because patients can't stand it. They have to walk with this pump on a, it's difficult. And then we look for a day or two. We calculate the insulin doses, we prescribe insulin, and then we check it for a day or two. And we adjust basal and prandial insulin the same day. It only depends on your how clever patient is, how much they can adjust. Yeah.
Last question.
No, we stay here till 1 o'clock, so then we start another session. So you have as many questions as you like.
Sometimes we face cases type 2 diabetic on oral therapy. All of a sudden, they glycemic they are controlled glycemically, and they stop treatment for 4 months without treatment. What, like honeymoon period? What is your point of view about this? In
Well,
type 2.
Beta cells are very flexible, plastic, you could say. I mean, they very much react on glucose levels, and there is this concept of glucose toxicity. And we not very frequently, what we see very often is very high glucose at diagnosis, we give insulin. After 2-3 months, we stop insulin, and patients very often stay on metformin only. Sometimes, if they are able to lose a few kilograms, this is not even necessary. Because first, beta cell became more responsive to glucose levels, and this is what we also achieve with insulin infusion, intravenous infusion. But also, if someone lost a little bit of, it doesn't have to be a lot, it could be like 5-6 kilos, then the amount of insulin which is produced is enough for the current body mass. Because this is what really makes people diabetic, type 2 diabetic, that the body is not able to produce enough insulin to compensate insulin resistance. So yeah, we see it. I could show you the cases. I had a patient who came once to my office, and his blood glucose was 1500. So it was like 80 millimoles per liter. And he just walked in, 36-year-old, obese, but not exceptionally obese. He just went in, and we started to talk and said, look, doctor, my doctor checked my glucose and it's 1521. And I said, no, that's not possible. That's a mistake. And I immediately sent him to admission department. They checked his glucose. It was 1390 something. So we, of course, immediately put him to hospital. But you know what happened? He was treated with clozapine. It's it's a drug for schizophrenia, psychotic drug, a relatively new psychotic drug. Olanzapine, clozapine, there are new drugs, and they induce severe insulin resistance. And his HbA1c was 13. He was slow. His blood glucose was very slowly going up, and he tolerated 1500, which normally you have severe hyperosmolar coma, and you may die. And now he's only on metformin. He was discharged on insulin, and now he takes 1 gram of metformin per day. So absolutely, it's absolutely possible. As I said, in type 2, beta cells, the mass goes down, their function goes down, but they're still there. And apparently incretin-based therapies, incretin agents somehow are able to help beta cells function longer. Yeah? Okay.
How to break the circle between increased insulin and increased body weight, increased insulin, increased body weight. Add another drug, or it's about diet or what?
Well, it's all about changing human behavior, which is very difficult. There is a very good study. I don't have a slide here, but I used to show it. They did it in Vienna. They took patients, like you said, high insulin doses, obese. They had 1.5 unit of insulin per kilograms at least. And all they did is they put them on a low-calorie, low-carbohydrate diet for a week in hospital. Everything improved. Everything. Glucose requirement was cut down by 2/3, and they kept them for 1 week initially, then for another week, not changing protein content. So all in all, it was 2 weeks stay in hospital. Their HbA1c decreased by 1% in 2 weeks, which was amazing. The ketones, no, they were not hypos because the insulin was monitored, so they know they decreased it quickly. But just cutting down calorie intake worked perfectly. The problem is how to continue it after hospital. Again, I'm just sharing. I'm not really. We're not really teaching you here. We're just talking and we exchange experience. So another case I have now in my hospital. I even found yesterday. How is she doing? We have a 36-year-old lady whose body weight is 160 kilograms, and we put her after just 10 days in hospital. She lost 12 kilos just by eating. She's not starving. She says, I'm fine, I'm not in any hunger, but I asked our dietitian to prepare a diet for about 800 calories per day. This is the lowest level you can get from normal food. Well, it's mostly a little bit of vegetables and a piece of chicken, that's it. But then you develop mild ketoacidosis, and that blocks your hunger feeling. So, but my dietitian said, no, I can't do it for 800. I will do it 1,000. Okay, do it 1,000. I said she probably had 4,000 a day at home. So just by manipulating this, by just cutting down energy intake, you immediately increase insulin sensitivity. If you read about rat experiments, everything shows that longevity in rats is associated with high insulin sensitivity, and this is associated by mild fasting. I mean, little calorie negative balance, not a long one, but long term, just a little one. You basically have a nice tool in your hands, but it's difficult to use in practice because you have Ramadan. So that would be a nice thing. You have a whole day fast, but I understand people over the night, they compensated, yes? So that's the problem. If they fast during the day and they had little overnight, that would be great. 1 month fasting for all of us during the year probably would be a very good idea. But I used to work, when I was a student, I worked in England in a textile factory, and it was me and a group of guys from Morocco and Tunisia, and they were all Islam. So they described me in details what they do when it was Ramadan. They were angry when they work during the day, and what they do during the night, how much they eat. So, but that's how to break the circle. The other thing we do, I can tell you nowadays, when we think that patient is hyper insulinized, let's say, getting too much insulin, we add empagliflozin, SGLT2 inhibitor, and we even manage to stop insulin in some of these patients, because this is a powerful drug. People lose a lot of glucose with their urine, they lose a few kilos, and sometimes it's enough, especially they are, again, start controlling what they eat. So you might use this to break the circle. Combining insulin with SGLT2 inhibitor, probably doesn't matter which one. With SGLT2 inhibitor, doesn't matter which one. Any other questions? Well, we prefer empagliflozin. Absolutely. Do you have EMPA, because it has a nice study. But if you have only DAPA, there are countries where Interestingly, in Germany, they have only dapagliflozin. That's okay. You have empagliflozin here. The three. Yeah, okay. Well, DAPA is weaker. Might be. My 80% of my patients are on EMPA now. So we simply stopped prescribing DAPA, not because we don't like it, but because EMPA has very good studies. Let me ask someone in the back. Yeah.
Thank you. I'm asking about middle-aged people around 30 and 40. First time diagnosed with diabetes, coming with HbA1c 13 or 14. We wondering, is it type 1 or type 2? And would you prefer to start with insulin directly or oral hypoglycemic drugs and see the outcomes? And also, how do you follow those patients? Do you follow them with HbA1c? Tell the patient you should wait 3 months to see your HbA1c, or with fasting with postprandial?
If you have a newly diagnosed patient with HbA1c of 13 or 14%, I'm almost 100% sure they are type 2 diabetes, because that means they must have had high glucose for a long time. And it's pretty impossible in type 1 diabetes to have months of high glucose and no other symptoms. Type 1 diabetes, the moment 80 to 90 beta cells are damaged, it starts pretty abruptly, and usually on average patients have like 1 month of history of symptoms. The patient I know with the longest history of symptoms had clearly signs of hyperglycemia for a year, but he was a businessman, very successful one. He was in his late 30s and he said, no diabetes, I'm always healthy, nothing happens. He eventually went into severe coma. His pH of his blood was 6.8 something, very low. He spent a month at intensive care unit. He developed kind of lesions in his neck because he was just lying like that with all the pus infections. So now he's on insulin. He's clearly type 1, but he managed to hold the symptoms for 1 year. But this is an exception thing. And even then his HbA1c wasn't that high as far as I remember. So if you have a 13, 14, they must be type 2. And then it's the question, what is their blood glucose at present? Because if it's high, like 300, 400, it would be difficult for oral agents to work. Because if someone is so much glucotoxicized, yes, you might say, you need insulin. But again, I saw patients whom, when we explained everything, they started just on metformin and it worked. But with oral agents, it will take more time. So insulin, again, is not a drug of choice for type 2 diabetes. The funny thing with type 2 is the moment you diagnose it, whatever you do, it will get better. They will either change their food pattern a little, at least decrease carbohydrates. They will take metformin, any other agents. And we follow them with HbA1c. You can follow them whatever is possible. If HbA1c is not available, be it fasting glucose. But HbA1c is the best one because it is, all the complication risk is calculated against HbA1c levels. So that's how I would do. And also, in patients with such high HbA1c, I wouldn't be very fast in lowering blood glucose, because the patients will feel unwell. And we all know that 400 milligrams per deciliter of hyperglycemia doesn't kill you in a day. It will kill you in 3 years. And so it's like blood pressure. If someone had a high blood pressure for a long time and you immediately give them all the drugs and bring blood pressure to normal, they will feel horrible. And they will stop taking medication. So I usually tell the patients, look, it took you a few months or maybe even years to go on this high mountain of HbA1c. And we can take an elevator and bring you down with insulin, or we can take some slower measures and slowly bring you down. And you will feel okay. You will not feel bad because of such abrupt changes. This is how it's probably the best thing to do. But the best thing, if you have doubts about type 1 or type 2, you should measure gut autoantibodies. But I haven't seen someone with type 1 with such high HbA1c. It doesn't last that long. Any other questions? Yeah. Yeah. Can you? Yeah. The gentleman there, or maybe the lady first. Yeah.
Please, I want to ask you that I have a patient before the fasting blood sugar was about 400 or 300, and then after controlling him, he said that he feel dizzy when the fasting blood sugar dropped to 110 or 120, and he used to take sweets and something like that. I told him that it's not hypos.
No, it's the explanation is probably simple. It means that for a long time he had this 300, 400, and anything lower, which is, and 100 is much lower, is recorded as hypoglycemia. In patients with, it's a historical name, but we still use brittle diabetes, with someone who has very changing blood glucose. If someone has glucose 300 and then in a very quick short time got like 200, which is still far from hypo, but just the speed with which glucose is lowered is going down, it may also cause symptoms of hypoglycemia. I can tell you the other example. We once described the case of patient with insulinoma. So you know what insulinoma is, the bouts of insulin release. She fainted only when her blood glucose was 18. She had positive starvation or hunger test. It took us 2 years it was years ago, before CT scans were popular. It took us 2 years to find a 5 millimeter tumor in her pancreas. And she was operated, and very successfully. So her blood glucose from 30 to 50 went to normal levels. You know what? She had all normal levels, like 100, 90. She had all the symptoms of hyperglycemia. She had thirst, increased thirst, she had polyuria, and we said, how come? I mean, your glucose is normal. So that's the level of adaptation of our body. But it takes time. I mean, a few months, the patient will tolerate 100 very well. Okay, you had a question? Yeah.
First of all, I want to thank you for this course and for this event. Then I want to ask about if I have a patient that's on anti-epileptic drugs.
Anti-epileptic?
Yeah. Will I need to adjust or minimize the dose of the treatment as anti-epileptics act on the cytochrome P450? So I will need to minimize the dose so as not to have hypoglycemic attacks or not? And if yes, how will I do that?
Is the patient treated with insulin? No. With oral agents?
Yeah.
Because with insulin you don't have to do anything. I understand the risk, the question, the reason you ask the question is that hypoglycemia might facilitate seizures. Yes, if the glucose goes down, you might have seizures, and it might be difficult to see the difference between hypo and epilepsy. As far as I remember, as far as I know, the only group of drugs which is metabolized with this CP450 are sulfonylureas. So the patients on sulfonylureas, I would decrease the dose. I would probably, well, one thing I would do, I would first of all try to use the drugs which do not cause any hypo. So I would try to avoid insulin, but if you have to, you have to. And I would stop sulfonylurea for sure and use other drugs. Pioglitazone, DP4 inhibitors, SGLT2, they don't cause hypoglycemia. So, and these drugs are safe. They basically, they don't interact with CIP450. Yeah. Okay.
Thanks.
But that's interesting. Epilepsy is one of the diseases which is rarely associated with diabetes. There are two quite often diseases which are not very frequent or less frequent statistically in patients with diabetes. One is epilepsy, and the second one is prostate cancer. Type 2 diabetes increases the risk of all the cancers, but not the prostate one. It doesn't mean the patients don't have it, but the risk is decreased. And it's well understood why. Any other questions? Oh, we can always count on first row.
In the case of my colleague, hemoglobin A1C 14 and blood sugar is 400. When I prescribe the drug, how long time the second visit would be, and target hemoglobin A1C?
Well, it should be, it depends on what drug you use, but if it's insulin, the visit should be pretty quick. If it is metformin, you can see the patient 2 to 3 weeks, because metformin takes again 2 to 3 4 weeks to develop its potential. The same DPP4 inhibitors. SGLT2 inhibitors are much faster. But what I do, I don't know if you are used to do it, but what I do, I just give my phone number and I ask patients to call me. I could live in outpatient clinic. I could live there 24 hours with the patients you have. Probably you could also. So I just give them my phone number and tell them, call me in a week or call me anytime if anything goes wrong. It saves time. And I tell them, don't look for answers in the internet because you will find plenty of weird answers. I always tell them, I never laugh at patients, I never shout at you. I mean, there are no stupid questions, just call me. And I'd rather have them calling me, you know, with petty things and then just have a 5-minute discussion on the phone and it's easy, than they come to me when there is something serious. Both. Basically, the full control of diabetes is HbA1c, fasting, and postprandial. And you have to know all these three to know whether the patient is well treated. Because you might have HbA1c which is fine. I could show you CGMS data where HbA1c is 7, okay, but patient has frequent hypos. So if it is like someone in whom good glucose control is really important, so rather younger people, in pregnant women, then all these three things are important. When I have 70-year-old, you know, and the disease is not very much advanced, sometimes just fasting is okay. But basically we need all these three, and especially if you want to make a decision on the treatment, because metformin is affecting more fasting than postprandial, let's say, like DPP4 inhibitors are more affecting postprandial rather than fasting glucose. There are tiny differences, but there are. So, you know, I have to know the profile and to change the medication. Well, 3 months at least, 3 to 6. And well, the HbA1c 14, I would say, I usually set the goals with the patients. Yes, when we start the treatment, I say, look, your glucose control is awful, everything is wrong here, but we will improve it. And we will be happy if in 6 months' time, from 14%, we'll get to 7 or 8. Yes? And I always try to be positive. Yes, when they... Well, I don't know. I would start with metformin, see what happens. If the diagnosis of diabetes is a tricky moment because people do not want to have diabetes. That is the only moment in my experience when you can really change the lifestyle. Yes, if someone has diabetes for 10 years and comes to you and has high glucose and say, oh, you should eat less or don't eat this and exercise more, say, oh, come on, I've been living with this disease for 10 years, nothing really happened. There's no pain, whatever. But if they have diabetes, say, oh, no, I haven't been eating so many sweets, why should I have diabetes? And this is a shocking news for many. And regardless whether you live in Egypt, wherever, Syria, Pakistan, Mongolia, Poland, US, that's for most of the people, we're all humans. It's shocking news. And that's the moment you can change their lifestyle. So you can say, look, this is what you've been doing wrong by eating this or not exercising enough, and then you can change this. And up to 20-25% of patients do change their lifestyle, and sometimes only metformin as an additional drug is okay. But there are patients who say, no, I will not change anything. I could have diabetes, syphilis, whatever. I will not change anything. Then you have to give metformin and 2-3 other drugs or even insulin very quickly. It's very, very individual. And it takes time. You have to understand what this patient really, what is important for him. It's a kind of a dialogue you should engage with. That's the ideal situation. Say, okay, what is important for you? Do you want to have good blood glucose or maintain your body weight or lose body weight or not to go blind or to keep your job, for example, yes? And then you have to adjust the treatment. Yeah? At the very beginning of the disease? Well, I started when it's like 400 or high, I usually give insulin. It all depends. I can't tell you. Sometimes it's just for 2 weeks. I don't know. It's just we give it. I always tell the patient, look, this is the drug I think is good for you. I really have no idea how it is going to work. So start taking it and let me know if anything goes wrong. And this is my phone number. So that's why I hate phones, by the way. But 3 treatments, yeah.
You can.
I withdraw. In the past, with high blood glucose but not requiring insulin, we started at the same time metformin and sulfonylurea. We gave 2 drugs together, and then I stopped sulfonylurea and remained metformin. So, yeah, but again, it's very individual. Yeah.
How do you see sulfonylurea in the next 10 years? If the patient comes with on sulfonylurea and the hemoglobin A1C is good?
Well, if it's okay and no hypos, we have a saying in Poland that the better is the enemy of the good. So if it's good, if it's okay, but we only use one sulfonylurea, we only use glyclazide nowadays. We withdrew from glimepiride because of hypoglycemia risk. Yeah? What time is it? Sorry, we should start the next session. Thank you. No, I can answer any questions when we finish the next session. Metformin I prefer, long acting.
Which metformin you prefer, conventional or extended release?
No, extended release. Okay. Extended release because it's clearly well tolerated. But you have to give proper, which means high doses like 1.5, 2 grams at night. But I usually start, if there are symptoms if the glucose is not very high, I start at bedtime insulin. Well, thank you very much. You've been wonderful, but we have to finish. There is a next session to start. Thank you.